So 26 years in oncology, I grew up pre-Oncotype. Okay, I don't work for those people, but I was an early adopter. And this is how we made decisions. We used adjuvant online, right? And it was all about how big is the tumor, how high is the grade, were they node positive? You know, we looked at all these things, and they're still prognostic, don't get me wrong. But back then, we didn't even have Oncotype to help us decide. Everybody got chemo, right? Do you remember those days? So 1 centimeter node negative, they got 4 cycles of standard AC, which now horrifies me, right? Because a lot of those people really could have had much better benefit. So all of those things are prognostic, but none of those are predictive for benefit for extended endocrine therapy, okay? So that's where BCI really fills that void. And we get 2 pieces of information. So when I talk to my patients about it, I tell them you get this new prognosis. It'll give us an actual percentage of what your risk of developing a recurrence is. And then if you have some risk, it'll be predictive. You get a very clear piece of information. You're either a yes or you're a no as to whether or not you benefit from extended endocrine therapy, and that whether or not it makes it worthwhile to struggle with those AEs and the side effects that we see. So if you've not used this before, this is what a report typically looks like. So this patient had an 8% risk, and they're a yes. And when this slide was made, we were giving you an average, we were giving you the full data. So it's a 58 to a 71% risk reduction. Now they're averaging it. So you get, to me, it's a little cleaner report. You get a single percentage. So for instance, 10% drops to 3.5. So it's a pretty significant benefit if you're a yes. Down in the bottom is the dreaded no, right? So if they're gonna have risk, we all want benefit, right? So we're gonna talk about that as well. How do we handle those patients? So it's now in guidelines. So not only part of ASCO, but also part of NCCN guidelines. So I think that gives BCI more credibility. It certainly is helping us with payers, but my patients also want to know that we know what we're talking about when we make these recommendations, right? So ASCO is consistent with what Biotheranostics recommends. So it's up to 3 positive nodes, so don't be afraid to order it on node positive, and up to a T3, and they agree with the data. You could have had tamoxifen, an AI, or a sequence of them, and also very strongly that the other tools in our toolbox are great for prognosis, but they're not predictive for benefit from extended endocrine therapy. NCCN even went a little bit further and said, listen, if they're a yes, they benefit. So you should be offering this. And if they're a no, they have no benefit from extended endocrine therapy despite our angst. So here are the tools that NCCN recommends and recognizes for all the things that we've got in our toolbox, right? So I'm a big Oncotype user, and all of these are prognostic, right? Oncotype is predictive for benefit from chemotherapy, but none of the rest of them are predictive for the next question, which is what do we do at year 5? Only BCI is actually predictive for that information. So how do we rely on this? So we've got all these clinical trials. So the original one was Stockholm, which was the proof of concept, and this was back when people didn't actually get anything. They just had their surgery, maybe radiation, and off they went. So this was 600 patients that were randomized to tamoxifen or nothing, and those that were a yes had a 65% reduction. And you can see across these, you've got anywhere from 58 to 71%. And a couple things that give us good confidence, TransAtom was an all-node positive study. So these were not little itty-bitty tumors that were all node negative. These were, I think, the patients that we see every day. So lots of data, over 4,500 patients.